This conference will now be recorded.
Welcome, dear guests and dear friends, again to the online ECG webinar. This ECG webinar is a common project of Mentor Medicine and Online Cardiology Club for you. My name is Sercan Okutucu. I am a cardiologist from Ankara, Turkey. And thanks all for the yesterday. We had a good session. Thanks for the Professor Dinaldo Oliveira for the nice presentation. And for the ones who missed the session, you can watch the presentation from the link that Chietza shared with you. Before we start, firstly, for the ones who are new on this platform, you can write your questions or comments to the chat box. And I am today's digital moderator, and I will ask them to our speaker after the presentation. Today, we have two really experienced cardiologists, Ümit, Yaşar, Sinan, and CENGİZ ŞABANOİ. We are really lucky to listen them, and thanks a lot to them. So I will now show today's program, and I will share my screen with you. This is today's program. We will start with ECG and conduction disturbances. Ümit, Yaşar, Sinan will present it. And after the presentation, we will have some time for questions and answers. Then CENGİZ will present the ECG in chamber enlargement. Then also we will have time for questions and answers. So now I will stop my screen sharing. And now I'll send the request to Ümit, Yaşar, Sinan. Ümit, Yaşar, Sinan, thanks again, and the stage is yours. You can start whenever you wish.
It's my pleasure. I'm waiting for the screen share. Okay. Could you see my screen?
Yes, it's perfect.
And now slideshow. Okay. Hi everyone again. This is Ümit Yaşar Sinan from Istanbul University Cerrahpaşa Institute of Cardiology, Istanbul, Turkey. First of all, I would like to thank Online Cardiology Club and Mentor Medicine giving me this chance to present this topic. It's a great pleasure for me. Today, at first, I will summarize the normal electrical conduction system. Then I will talk about the conduction disturbances, which means heart blocks and abnormal conduction. The cardiac electrical conduction system is consisted of sinoatrial node, AV node, His bundle, and Purkinje fibers. Except this, also atrium and ventricular myocardium has a potential to generate electrical activity. Among all of them, the sinoatrial node is the dominant pacemaker in the heart conduction system because it has a less negative resonant membrane action potential. It can increase the action potential to the critical threshold to make a new beat. So the electrical activity follows this predefined pathway. It travels from the sinoatrial node to the AV node, then His bundle, then right and left bundle branch, and it finally ends up in the Purkinje fiber, which radiates to the ventricular myocardium. And also left bundle branch has two components. One of them is left anterior fascicle, and one of them is left posterior fascicle. Heart block can occur anywhere in the conduction system, beginning from the sinoatrial connection, then AV junction, the bundle branch and their fascicles, and finally in the subventricular Purkinje fibers. Today we will talk about these heart blocks. And also there are 3 degrees of the conduction disorder. One of them is first degree. It may manifest as slow conduction. The other one, intermittent block, classified as second degree. And the other one is the complete block, classified as third degree. And there are 2 types of the second degree block. Type 1 is Venkeba, type 2 is Mobitz. There are 2 types heart block originating from the sinus nodes. One of them is sinus arrest. These are the characteristics of the sinus arrest. There is the sudden cessation in electrical activity in sinoatrial node. As you see on ECG trace, there is a pause in the electrical activity. Because of the sinoatrial node cannot be depolarized, there is no P wave and there is no follow-up QRS complex, this P wave. So it can be seen in healthy individuals as a normal physiologic variant up to 2 seconds. But however, the pauses lasting longer than the 3 seconds is a marker of the 6-unit syndrome. If sinus arrest can persist enough, the atrial nodular ventricular escape beat may be seen. The other block originating from the sinoatrial node is sinoatrial exit block. Different from the other one, the depolarization of the sinoatrial node is normal, and the pacemaker impulse is failed to propagate beyond the sinoatrial node. So there is intermittent failure of the atrial depolarization, which is seen as a drop P wave on ECG. There are multiple examples of the PP interval, and this is different characters from the sinus arrest, and is classified as first, second, and third degree block. As you can see on the ECG trace, there is no P wave and follows no QRS complex because of the synaptic exit block. The deposition of the synaptic is normal, but there is an exit block, so the atrium did not deposit. Now we can talk about the AV block. There are three types of the AV block. One of them is first degree AV block. Yesterday, Sercan presented us the normal PR interval, QRS interval, and QT interval, the normal characteristics of the ECG. The normal PR interval is between 120 milliseconds and 200 milliseconds, which means smaller than the 5 small score on the ECG. We know 1 small score is equal to 40 milliseconds and 5 small score is equal to 200 milliseconds. First degree AV block is diagnosed when the PR interval is longer than the 200 milliseconds. It is common among older patients as a normal variant, but increased vagal tone, rheumatic fever, inferior myocardial infarction, athletic training, valvular surgery, electrical disturbances, AV nodal blocking drugs like beta blockers, calcium channel blockers, digoxin, amiodarone are possible causes of the first degree AV block. This is animation of the first degree AV block. The electric impulse originating from the synaptic node coming to the AV node, and it is conducted with delayed conduction. As you can see on the ECG tracing, the PR interval is longer than the 200 milliseconds and fixed. There is a fixed prolonged PR interval, and all P wave followed by the QRS complex. This is the example of the first degree AV block on ECG. As you can see, all P wave is followed by the QRS complex, and PR interval is fixed prolonged. It is almost about 400 milliseconds, nearly twofold increase. Type 1 second degree AV block, called as VENTRICULAR, there is a progressive prolongation of the PR interval, different from the first degree AV block, because there was fixed prolonged PR interval in first degree block. There is progressive prolongation of the PR interval. And finally, one of the P wave will not conduct to the ventricle, and there will be no QRS complex after the P wave. The PR interval is longest immediately before the drop bit, and there is relatively constant PP interval, and we can figure QRS complex with ratios of 3:2 or 4:3 or 5:4, which means in here, one of 3 P bits will not follow by the QRS complex. VENTRICULAR is usually due to the reversible conduction block at the level of the AV node. It's a benign rhythm causing minimal hemodynamic disturbance, and it has lowest progression to the third degree heart block. So asymptomatic patients do not require treatment. Symptomatic patients usually respond to atropine. Permanent pacing is rarely required. As you can see in the animation, the first beat P wave is followed by QRS complex and PR interval is normal. Then the second beat, the PR interval is getting longer and longer. There is a progressive prolongation of the PR interval, and there is a P wave is not followed by the QRS complex, and it means atrial deposition did not conduct to the ventricular myocardium. There must be a QRS complex, but it didn't seem. This is the animation of the second degree AV block. The electrical activity coming from the synaptic node to AV node, and it is conducted progressively delayed to the ventricular myocardium, and there is a P wave not followed by the QRS complex. The PR interval is progressively prolongation, and there is a non-conductive P wave on the ECG trace. This is an example of the VENTRICULAR. As you can see on the ECG, the PR interval is progressively prolongation, and there is a non-conductive P wave here. Type 2 second degree AV block, called as MOBITS. There is a failure of the conduction at the level of the His-Purkinje system below the AV node. There is intermittent non-conductive P wave without progressive prolongation of the PR interval Also, this is different from the type 1 second degree AV block because, as I said, there is progressive prolongation. There is no progressive prolongation. PR interval is normal or fixed prolonged, and one of the P wave will not conduct to ventricular movement, will not be followed by the QRS complex. It is related with the structural damage to the conduction system. Example, infarction, fibrosis, necrosis. We can see no specific pattern on ECG or fixed specific pattern like 2-to-1 block or 3-to-1 block, which means one of the P wave will not be followed by the QRS complex, or one of 3 P wave will not be followed by the QRS complex. This is the animation for the second degree AV block type 2. As you can see, the first initial PR interval is normal, and second PR interval is also normal, third PR interval is normal, and all 3 P waves followed by the QRS complex, and the fourth P wave, non-conducted P wave, and there is no QRS complex after the P wave. There is no progressive prolongation. The PR interval can be normal or can be fixed prolonged. There must be a QRS complex, but not. This is the animation of the second degree AV block. The electrical activity coming from the synaptic node to the AV node. And one of the beats will not conduct the ventricular myocardium, and one of PR will not be followed by QRS complex. This is another example of the second degree AV block with a 2-to-1 ratio. Each 2 of P wave, one of them will not be followed by the QRS complex, the other one will be followed. This is the 2-to-1 ratio, second degree AV block. There is fixed PR interval, normal or prolonged, and one of 2 P wave is not conducted, not followed by QRS complex. This is the ECG example. As you can see, one of 2 P wave will not follow by the QRS complex, the other one will follow by QRS complex. Third degree AV block, referred as a complete heart block. There is no conduction through the AV node, and there is a complete dissociation of the atrial and ventricular activity, which means ventricular activity being conducted at their no rate and atrial activity being conducted at their no rate, totally independent of each other. And there can be a ventricular escape rhythm originating from the AV node or bundle branch Purkinje system. If it's originating from the AV node, the QRS complex will be narrow. If it's coming from the bundle branch Purkinje system, the QRS complex will be wide. There's the AV dissociation among the atrium and ventricular myocardium. AV dissociation can be seen into critical station. One of them is AV block, third degree, one of them is VT. Dinaldo yesterday presented us the VT examples and characteristics. In VT, the heart rate is fast. In AV block, the heart rate is low. This is the difference of the both two clinic situation. Etiologies for the third degree AV block is idiopathic fibrosis and sclerosis in half of the patient. The second most common reason for the third degree AV block is ischemic heart disease. The other reason, drugs like beta blocker, calcium channel blocker, digoxin, amiodarone, myocarditis, cardiac surgery like mitral valve repair, pathology of fall repair, congenital and genetic disease. This is the example of the third degree AV block. As you can see, the ventricular activity being conducted as their own rhythm and atrial conduction being transferred at their own rhythm, totally independent of each other. The PP interval is regular and RR interval is regular, and QRS complex is wide, which means the escape rhythm originated from the below the AV node from his bundle or Purkinje fibers, and totally independent of each other, P wave and QRS complex. This is the animation for the complete AV block. As you can see, no relation between the P and QRS wave, and atrial rate is faster than the ventricular rate, and QRS wide generally, but not always. This is the third degree AV complete block with wide QRS complex. The escape rhythm originated from the below AV node, and PP interval is regular, RR interval is regular, totally independent of each other. This is another example. This is the third degree AV block with narrow QRS complex. It's originated from the AV node. This example for the, again, third degree AV block with wide QRS complex. The ventricular rate about, as you can say, 1, 2, 3, 4, 5, 6, 10 beat square. It means 30 BRPM ventricular rate. And atrial rate is faster than the ventricular rate. This example for the third degree AV block with narrow QRS complex. The ventricular rate is almost 40 BPM. And the heart block can be occur in the below the AV node from the branch block. There is a bundle branch block like right bundle branch block, left bundle block, or there are hemo blocks like left anterior fascicular block, left posterior fascicular block, and it can be come together like bifascicular block. Example of right bundle branch block plus left anterior fascicular block, right bundle branch block plus left posterior fascicular block. This is the mechanism of the right bundle branch block. The electrical activity coming from the synaptic node, AV node, then it's blocked in the right bundle branch. The QRS duration is wide, longer than the 120 milliseconds, and there is a, in right precordial derivation, there is small r, deep and widest, and tall r, like a bunny ear, RSR complex. And in left precordial and lateral precordial derivations, there is a deep and wide S wave. This is the characteristics of the right bundle branch block. When we see the right bundle branch block, we can see as a normal variant and the other pathologic causes of the right bundle branch block: atrial septal defect, tetralogy of Fallot, ischemic heart disease, hypertension, pulmonary embolism, cardiomyopathy, myocarditis, pericarditis, and rheumatic valve disease. And this is the mechanism of the left bundle branch block. The electric activity coming from the synaptic node to AV node, then it's blocked in the left bundle. And the QRS duration again is wide, longer than the 120 milliseconds. And there is QRS complex in right precordial derivation and left precordial derivation, and also D1 show a RSR pattern, which is characteristic of the left bundle branch block. And there is QRS disorgan with ST sigma and T wave. The left bundle branch block is almost always pathologic. The reason for the left bundle branch block can be ischemic, hypertension, or aortic stenosis like pathologic process. This is the characteristic of the right bundle branch block and left bundle branch block and comparison of both them. As you can see in right precordial derivation, in right bundle branch block, there are RSR pattern like bunny ears, and in left precordial derivation, there is deep and wide S wave and QRS duration is wide. Left bundle branch block in right precordial derivation, there is QRS pattern, and in left precordial derivation, there is RSR pattern and QRS duration again wide. This is the example for the right bundle branch block in right precordial derivation, which means V1 to V3, there is RSR pattern like bunny ear, and in left precordial derivation, there is deep and wide S wave, and also right axis deviation. This is the left bundle branch block pattern. As you can see, in right precordial derivation, there is QRS complex, and left precordial derivation, there is RSR complex, and QRS is wide. This is the example of the right bundle branch block with atrial fibrillation. Yesterday, the another showed us arrhythmias. As you can see, the RR interval is irregular, and also there is no P wave, characteristic of the atrial fibrillation, and also there is RSR pattern in the right precordial derivation, which means right bundle branch block. This is the example of the left bundle branch block with atrial fibrillation. Again, RR interval is irregular, and also there is no P wave, and there is RSR complex in left precordial derivation and QRS complex in right precordial derivation. Now, hemo blocks, left anterior fascicular blocks, have a left axis deviation usually between -30 and -90 degree. As you can see on ECG tracing, in lateral derivation like D1 and AVL, there is small Q and tall R wave, and inferior derivation, there is small r and deep wide S wave. This is the characteristics of left anterior fascicular block, and QRS duration is below the 120 milliseconds, which is narrow. This is the example of the left anterior fascicular block. As you can see in D1 and AVL, there is small Q wave and tall R wave, and in inferior derivation there is small r and deep S wave. And when we look at the axis deviation, there is positive in D1 and the Cuirass complex is negative in D2. It means there's a left axis deviation. Left posterior fascicular block creates the right axis deviation. And on ECG tracing, you can see in D1 and AVAL there is a small r and deep S, different from the left anterior fascicular block. In inferior derivation, there is small q and tall R wave. And Cuirass deviation is again narrow. And there should be no evidence of right ventricular hypertrophy and any other cause of the right axis deviation. This is the example of the left posterior fascicular block. In D1 and AVL, there is small R and deep S wave. In inferior derivation, D2, D3, AVF, there is small q and tall R wave. And when we look at the axis, in D1, it's negative, this side, and in D2, it's positive, this side, which means right axis deviation. This is typical fascicular block example. There is right bundle branch block, as you can see in right precordial derivation RSR pattern, and also in D1, small q, tall R, and inferior derivation, small r, deep S wave, right bundle branch block plus left anterior fascicular block. This is the example of the right bundle branch block plus with left posterior fascicular block. Again, RSR pattern in large precordial derivation, and D1, small r, deep S, inferior derivation, small q, tall R wave. Lastly, this is the trifascicular block example. There is again right bundle branch block, as you can see in right precordial derivation, like Bonier's RSR pattern. And also, there is left anterior fascicular block, which can see in D1 and AVL. There is a small Q wave, tall R wave, and inferior derivation, there is small R wave and deep S wave. And also, the axis is left, there is a left axis deviation. And also, there is the first degree AV block, which can see in PR interval longer than the 200 milliseconds. And all three together make a trifascicular block. It can be progressed to the AV complete block. Thank you very much for your interest.
Thanks a lot, Ümit, for this excellent presentation, and your slides were perfect. We enjoyed a lot. Is there any question about the presentation? Now I'll share my screen and any questions or comments from the attendants, from our presenters? There is one question from Nokuzula Nicole, and it is about the fascicular blocks. I didn't understand the fascicular blocks. One more time, please.
Okay, I will show again.
I will send again request to you.
Okay, please.
We can see your desktop now.
Okay. Hemiblock, fascicular block come from the left bundle branch. As I said, left bundle branch has a two components, left anterior fascicule and left posterior fascicule. If the block is coming from one of them, there will be a hemiblock. I will show the example again. Sorry. Yes. It can be come from the left anterior fascicular, or it can be from the left posterior fascicule. I will come to example. Yes, this left anterior fascicular block, in lateral derivation, there is small Q wave and tall R wave. Conversely, in inferior derivation like D2, D3, A wave, there is small R and deep S wave. The positive is dominant in lateral derivation the negative wave is dominant in inferior derivation, and the axis is left axis because it's positive in D1 and it's negative in D2. This is the example for this. As you can see in D1 and AVL, there is small q and there is a positive tall R wave. And it's totally positive axis. And in inferior derivation, there is small R wave and deep S wave. It's totally negative reflection. And D1 is positive, makes a vector this way, and D2 is negative, the total of the QRS complex. So this in this way. So it makes a left axis deviation. Yesterday, Serjan presented to calculate the hard axis wave. And this is the left posterior fascicular block example. It is different from left anterior fascicular block. Now, there's a small Q wave and tall R wave in inferior derivation. And there is small R wave, deep S wave in D1 and AVL. It's contrary from the left anterior fascicular block, and there is right axis deviation because of the total QRS vector is in the negative way, and in the ECG derivation, the QRS complex totally is positive. Make a vector like this, so axis is right axis deviation. This is the example for it. In inferior derivation, there is small Q wave, tall R wave. In the end AVL, there is small R wave, deep S wave, and the axis deviation in the right way. Is it clear? Is it okay now?
Yes, I got it. Thank you very much. I understand now. Thank you.
You're welcome.
Okay. Any questions about presentation? Any comments? And I would like to ask one question. I would like to ask about, of course, the presentation is perfect. So I'd like to ask about clinical aspects. I mean, which conduction disturbances are dangerous? That I mean, how we should approach to these conduction disturbances, which are benign and which are dangerous, and when a patient come emergency department with this conduction disturbances, and how we should approach.
Exactly. Usually, sinus arrest synarterial exit block is not symptomatic. The patient is asymptomatic and not required any intervention. But and also first degree and second degree AV block is hemodynamically stable patient. There is no necessary to implant a pacemaker like that intervention. But in third degree AV block, the patient could be symptomatic and there will be hemodynamic instability. So permanent pacemaker or not permanent pacemaker may be necessary in that situation. And also trifascicular block can progress to the third degree AV complete block, so it will be dangerous for the patient. It will be necessary pacemaker maybe for that patient.
There is one question about trifascicular block. They ask that could you please help us to understand the mechanism of trifascicular blocks? Okay. I mean, what's trifascicular block?
The trifascicular block has three components. One of them is the first degree AV block. It shows with prolonged peri-interval, fixed prolonged peri-interval. And the other component is right bundle branch block. And both of them could be together with the left anterior or left posterior fascicular block. There are three different points for the block. So totally it can create a AV complete block. So it can be dangerous. It can turn to the third degree AV block. There may be a permanent pacemaker need.
Thank you very much. And you told to us about the bunny ears. When we tell them bunny ears is this. So this one. So when we see bunny ears in V1, it should be what?
Right bundle branch block.
Yeah, when we see this bunny ears in V1, it is right bundle branch block. And when we see this bunny ear in the V5, V6, then it should be left bundle branch block. Yes, and I don't have any questions more. If you want to ask any questions or comments about this presentation.
I want to say something more. And also left bundle branch block is almost usually has a pathology process like ischemic heart disease or another condition pathology process. Right bundle branch block can be seen in normal patients without any pathology.
Yes, thank you very much. And sometimes about this axis things, I made a little paperwork for understanding when I was student. I want to show to you. This is the conduction system, and like this is the AV node, and here the right bundle branch, and the left bundle branch, and the left anterior fascicle. This one. And that one is left posterior. So when there is block here, the electrical conduction will come here and turn to this side. So there will be the left axis in the case of left anterior hemiblock. And when there is left posterior hemiblock, the conduction will come from here and turn to here. So there will be right axis deviation. You can do by yourself with that paper, and you will understand better and how the axis will shift. Özge asking, are left bundle branch block or right bundle branch block acute conditions?
Yes, sometimes left bundle branch block can occur in acute phase with a chest pain, and it shows that it's the sign of the anterior myocardial infarction sometimes.
Yeah, this is very, very important point. Yeah, if the patient has the typical chest pain and with left bundle branch block, then it can be a STEMI also. And so now I will send the screen sharing request to CENGİZ, and we can pass, I think, the second presentation. Thanks a lot to Ümit, Yaşar, Sinan. We enjoyed a lot and we learned a lot.
You are welcome. Shall I introduce to CENGİZ?
Do you see my screen?
Yeah, yes, Ümit, I think you are digital moderator in the half of the session, so you can introduce.
Okay, on this second session, we will go on with ECG in cardiac chamber enlargement. My colleague, Dr. CENGİZ ŞABANOİ, will present that topic.
Okay, it's a great pleasure to have this opportunity to present this presentation in such a good meeting. I will talk about ECG in cardiac chamber enlargements. I can skip the slides. Okay. Okay, as we know, there are different causes of cardiac chamber enlargements. Left atrial enlargement, right atrial enlargement. I will talk a brief about biatrial and biventricular enlargements. The left ventricular hypertrophy, right ventricular hypertrophy, and very brief information about low voltage ECG. Atrial activation occurs after impulse formation from the sinus node, and firstly right atrium is activated, followed by left atrial activation, sometimes with physiologic notching of the P wave. If an atrium becomes enlarged, typically as compensatory mechanism, its contribution to P wave will be enhanced, and enlargement of the left and right atria causes typical P wave change especially in leads 2 and V1. Now we see here the normal appearance of the activation of left and right atrium. Here we see the in the first part, the right atrium is activated, then in a V1 precordial derivation, then left atrium is activated and makes a negative component of the P wave. In a lead 2, we see the activation of right atrium, and it's associated with left atrium activation, and we see the whole P wave in this picture. It's a normal appearance. In the left enlargement, in V1 precordial lead, we see the first component is a component of the right atrium activation, but because of the left atrium enlargement, the negative component is increased in a P wave of V1 lead. In a second lead, we see the prolongation and the increase of amplitude of P wave, and it's the appearance with like a BFIT. In the right atrial enlargement, we see, we name it P pulmonale, as we mentioned before about P mitrale. This is P pulmonale. Here, the simultaneous activation is seen in a lead 2. The amplitude of P wave is increased and some kind narrowed, but there is no prolongation of P wave like in left atrial enlargement, as we see here in both in lead 2 and in V1 precordial derivation in right atrial enlargement. We see here the example which we can see in a ECG, real ECG. In a lead 2, we see the P mitrale, the BFIT P wave. It's some kind notched here, and in V1 precordial derivation, there is a negative component of the left atrial enlargement, the negative component of left atrial derivation, which reflects the left atrial depolarization here. Now, in these curves, we see the normal pattern of the activation of right atrium and left atrium. Firstly, as we know, the right atrium is activated, then the left atrium activated. But in left atrial enlargement, the activation of left atrium is some kind prolonged and delayed, and that's why the interpeak interval here is more than 40 milliseconds. As we mentioned before, it's named the P mitrale, and we see here in lead 2 the morphology of P wave. Here we clearly see the negative component of the P wave. It's because of left atrial enlargement, and here the negative portion of the P wave reflects the left atrial activation, and the upright portion of P wave reflects the right atrial activation. Now we can see what is happening in right atrial enlargement. As I said in the first slide of difference between right atrial enlargement and left atrial enlargement, here we see the P pulmonale waves. They are especially the increase in amplitude in inferior leads, in lead 2, lead 3, and here we don't see the any negative component in P wave, only the increased amplitude of P wave and no prolongation. And in lead 2, the amplitude is more than 2.5 millimeters or 0.25 millivolts, and in V1 it's more than 1.5 millimeters. In which situations we see the right atrial enlargement, especially right atrial hypertrophy, right atrial dilation, right atrial distension, and right atrial scarring, and some kind of interatrial conduction delays. And in contrast, as we said, to the left atrial abnormality, we don't see the prolongation, only the increase in amplitude. As we see here, again, the normal pattern of activation of atriums, and in the right simultaneous activation of both right atriums and left atriums and the increase in amplitude. And here in ECG, we will see it in this feature. The amplitude of P wave is increased and no prolongation, no prolongation more than normal limits of P wave duration. Let's talk about left ventricular hypertrophy. Left ventricular hypertrophy is a very frequently seen picture in ECGs of patients, especially in outpatient clinic. And the major derivatives which we have to pay attention are left derivations, lead 1, AVL, from V4 to V6 derivations. Here in these derivations we see the high amplitude of left derivatives of R wave of left derivations, and the S wave in right leads, especially in lead 3, AVR, V1, V2, and V3, the increase in amplitude, in depth of S waves we see in the left ventricular hypertrophy. We see these situations especially in hypertension patients. It can be, as we know, the hypertrophy of left ventricle happens. We see it in echocardiography in patients with these ECGs. It can be concentric, eccentric, and asymmetric hypertrophies. For example, we can see only septal hypertrophy or the global hypertrophy of left ventricle. Is usually result in increase in systolic pressure. And this pressure load most commonly occurs in, as I said, in hypertension, also in valve disturbances like aortic stenosis, or if there is a aortic outflow obstruction or left ventricular outflow obstruction. Also, there can be the volume load, which can be seen in a valve regurgitation such as mitral or aortic regurgitations and dilated cardiomyopathy. See, here we see also again the increase in amplitude in V5, V6, and the left axis we see the R waves are positive, and there's S waves in IVR and D3, and S wave in V1. Two important situation is worth mentioning: pressure overload and volume overload, which cause ventricular hypertrophy. I talked about the reasons of pressure overload or volume overload. In pressure, if there is a prominent pressure overload, we see some ST and T wave derangements. They may be caused by subendocardial ischemia or some repolarization abnormalities. Formerly it named strain pattern. At the moment we name it ST and T wave abnormalities of left ventricular hypertrophy. There is also tall R waves. It also we have a tall R wave in volume overload, but we can see some kind slight elevation of ST, like Sercan yesterday said. It's like a early repolarization, deep Q wave and inverted U wave, which can be seen after T wave. We can see this feature in some ECGs of left ventricular hypertrophy. And there is the prolongation of electrical impulse in a hypertrophied amplitude, and in the some kind of widening of QRS complex of its intrinsicoid. It's named intrinsicoid deflection. It can be in a second part of QRS. It's named intrinsicoid deflection. It can be more than 40 milliseconds. And we see also, as we said in previous slides, strain pattern. It's in a lateral precordial leads, V5 and V6, and D2 and AVF. We can see these ST abnormalities. I want to come to the previous slide. The left ventricular hypertrophy is maybe accompanied by some other ECG patterns, which mentioned previously. For example, we can see the left atrial enlargement again with this left ventricular hypertrophy here, the negative component of the P wave in V1, and we can see the pemitrale. You can, if you see attentively, it's a some kind of notch, bifid pemitrale in lead 2. Then we see the left axis here, left axis, and it's seen in the next ECG also. Here we see the left axis also, and again the biphasic P wave of because of left atrial enlargement. We can pay attention to these accompanying features in a ECG of left ventricular hypertrophy. And now we can diagnose, and there is no very sufficient voltage criteria which can be used in screening of left ventricular hypertrophy, both in left ventricular hypertrophy and right ventricular hypertrophies. But from the past times, we have been using this famous criteria for the diagnosis of left ventricular hypertrophy. The diagnosis of, commonly say, diagnosis of left ventricular hypertrophy is not only ECG diagnosis. We have to examine the patient, and especially in nowadays, echocardiography is very important. And not only ECG gives us the opportunity to diagnosis of this pathology, but in outpatient clinic, in emergency units, in clinics that you are working, you can easily direct the patient about this issue. In extremity leads, if the summary of R wave in lead 1 and S wave in lead 3, if it's more than 25 millimeters or 2.5 millivolts, the second pattern, R wave in AVL, if more than 11 millimeters, if R wave in AVF more than 20 millimeters, if S wave in AVR is more than 14 millimeters, it's parameters of extremity leads for voltage criteria. And here we can see the chest leads. The tallest R wave in V4, one of V4, V5, or V6 is more than, if it's more than 27 millimeters. And the summary of R wave in V4, V6, and deepest S wave in one of V1, V2, V3 is more than 40 millimeters, and deepest S wave in V1, V2, or V3 more than 30 millimeters. It can direct us to the left ventricular hypertrophy. And there are two Sokolov line index and corneal voltage criteria that I want to mention. The summary of S wave in V1 and R wave in V5 or V6, if it's more than 35 millimeters, and accompanied with the R wave in AVL more than 11 millimeters. It faces the Sokolov line index. The second voltage criteria, corneal voltage criteria, in males, if it's the summary of S wave in V3 and R wave in AVL more than 28 millimeters, and if in females it's more than 20 millimeters, it bases the criteria, voltage criteria for left ventricle hypertrophy. There are some other voltage criteria. I won't make you to be tired of them. You can only hear about them. It's Scott's criteria, Robert's criteria, and there is a one table where we can make a calculation of the Rommel-Estes point score, and if it's more than 5, it's definite left ventricular hypertrophy. Is 4 and below, it's probable, but it's not very important to remember these. Now I can switch to right ventricular hypertrophy. As I said before about left ventricular hypertrophy, there is the criteria are not very sensitive and specific, but it's direct us to diagnose it, to direct the patient in a right clinic, in the right doctor, to the right doctor. A right ventricular hypertrophy is present when there is a pathologic increase in muscle mass of the right ventricle. Pulmonary hypertension, pulmonary stenosis, congenital heart disease, the reasons that can make cor pulmonale, acute pulmonary embolism, and other severe lung diseases. The important thing we have to pay attention, we see the tall R waves in V1, V2, V3, tall R waves. It's important, and S waves in left precordial leads, and we can see the negative QRS in lead 1, and when we have a right heart axis, and positive QRS in V1, as I said. In another ECG, we will also see these criteria. Firstly, before the diagnosis of right ventricular hypertrophy, we have to exclude some other reasons which can make tall R waves in V1. One of them, true posterior infarct, right ventricular hypertrophy, ventricular septal hypertrophy, right bundle branch block, Wolff-Parkinson-White syndrome, and normal variants. And as Sercan yesterday explained, the early precordial transition, the R waves in V1, V2, and V3 are tall. In true posterior infarct, as Sercan explained it yesterday, we can make derivations in V7 and V9. We place them in a posterior part of the scapula on the left side of the patient, and if we have ST elevation, Q waves in V7 and V9, and ST depression in V1 and V2, it directs us to the true posterior infarct. Right ventricular hypertrophy that we are talking about, we have in ECG the right axis deviation. We can have right atrial enlargement, and secondary STT derangements, which we saw in left ventricular hypertrophy. And ventricular septal hypertrophy, as I said, the other name is asymmetric hypertrophy. We can see associated Q waves and also deep narrow Q waves in V7 and 9. Right right bundle branch block, like Ümit Sinan talked about. Wide QRS, broad S in V1, V6, R peaks late in V1, the bunny ear, as Sercan showed, and normal or broad S waves in V7 and V9 also can be seen if we make this ECG in the patient. And Wolff-Parkinson-White syndrome, it will be talked in next presentations. We have a short PR, the delta wave, and we can see also this delta wave in V7 and V9. When we exclude all these diagnoses, then we can easily say that yes, these R waves in V1 can be caused by right ventricular hypertrophy and diseases I mentioned before. And some criteria for right ventricular hypertrophy, I will try to make it simple. Firstly, as we said on ECG previous slide, the R wave in V1, and respectively the RS ratio also in V1 will be more than 1. But if we make derivations of V3, right V3 and fourth V4 that Sercan explained it yesterday, when we make a precordial leads on the right side of the patient, we also can see the R to S ratio more than 1 here, and R waves will be tall. Associated right atrial overload and RV strains, like we mentioned, can be seen also here. The main criteria for the diagnosis, right axis deviation of plus 110 degrees. Dominant R wave, which can be more than 7 millimeters in V1, and R to S ratio more than 1. Dominant S wave in left precordial leads, also deeper than 7 millimeters, and QRS duration less than 120 milliseconds to differentiate from right bundle branch block. And other supporting criteria, right atrial enlargement, PET pulmonale, we can see in V1 and lead 2, as I mentioned before. Right ventricular strain pattern, ST depressions in right precordial leads and inferior leads. And the patterns, the one more pattern of right axis deviation, as we can see in lead 1, 2, 3, in deep S waves in leads 1, 2, 3. Deep S waves in the lateral leads also can be seen in right ventricular hypertrophy. One more ECG practice for us. Here we see the tall R wave in right ventricular hypertrophy. Then we can see also the S wave in V5, S wave in V5, and also we can see the S wave in AVF and D2. And this situation can be seen in also the chronic obstructive pulmonary disease, but we will see the slow R waves, very slow, perhaps with a low voltage, which I will mention in next slides, because of emphysema. But again, we can see here the right axis deviation and delayed precordial transition zone, the counterclockwise deviation to V1, V2, and V3, as we see here, which can direct us to the right axis, and R in AVR also. Then we can see this because of the volume overload in right ventricle. For example, in ostium secundum atrial septal defect also, we can see here this feature. We can sometimes we may face with biventricular hypertrophy. It's difficult to differentiate them, but the main thing, we firstly, if there is a biventricular hypertrophy, we will see especially left ventricular hypertrophy criteria in this ECG, S in V2, and R in V5. We will see also R wave in V1 because of right axis deviation, which we characterize the right ventricle hypertrophy. Prominent R wave in V1 and V2 also is seen, and prominent S wave in V5 also is seen. Right atrial abnormality may be seen also here. Right atrial abnormality, sometimes we can see the evidence of left atrial enlargement also in biventricular hypertrophies. Let me talk briefly about low voltage on ECG. It's defined as peak-to-peak amplitude less than 5 millimeters in limb leads and less than 10 millimeters in precordial leads. In which situations can we see it? Obesity, chronic obstructive pulmonary disease, pericardial effusion, amyloidosis, and hypothyroidism. This ECG of pericardial effusion patient, we can see the low amplitude of R waves, especially here. Of course, we can also see in these all diseases such a ECG also. What we take from this presentation, there is no single best electrocardiographic criteria for diagnosis of hypertrophy of all chambers of the heart. In left atrial abnormality enlargement, we will see the broad and often notched P waves, as I said, in lead 2 and the P wave with a negative component in V1. Precordial lead. Right atrial abnormality enlargement is characterized by P waves. The difference between left atrium and right atrium, there is no prolongation of P wave in right atrial abnormality. The heightness of the P wave in right atrial enlargement. In left ventricular hypertrophy, QRS complex having increased associated ST and T wave abnormalities in inferolateral leads, evidence of left atrial abnormality and left axis deviation. In right ventricular hypertrophy due to right ventricular pressure overload in some diseases like pulmonary stenosis, pulmonary hypertension, chronic obstructive lung disease, characterized with an amplitude increase in R wave in a right precordial leads and S wave in right precordial leads, the increase in depth in right precordial leads of S wave, causing an increase of R to S ratio in right precordial leads, and the increase of S to R ratio in left precordial leads. Thank you for your attendance, and thank you for the organization of such a good webinar. I hope that my presentation will be useful for our doctors and friends.
Thank you, CENGİZ. It was a very well presentation. Now we can continue with the question and answer. From the audience, if there is any question, please write it on chat box or unmute your microphone and ask the question directly to the speaker. There are two questions from Serjan. At first, I will ask the first one, then I will wait for your response, CENGİZ, then I will ask the second one. Serjan is asking for that. What about the slim person with thin chest wall or an obese person? Can this alter amplitude of record voltage?
Yeah, thank you for the good question, Serjan. In thin persons, we see the increase in amplitudes of voltage of waves, especially we can see the increase in R waves in precordial, especially in precordial leads, and in obese patients, we will see the low voltage criteria, like I mentioned in my last slide. We can pay attention to that, and in obese patients, sometimes very in rare conditions, some kind of left ventricular hypertrophy patterns we can see, but we have to confirm it by clinical examination and echocardiography of the patients.
Thank you. The second question is, can you please give some clinical example about the pressure overload and volume overload?
About clinical example. Pressure overload, as I said in my previous slides, we can see from some valvular diseases. For example, aortic stenosis, we can see the pressure overload, and also we can see it in hypertrophic cardiomyopathy when we have a obstruction in left ventricular outflow tract and we have a gradient there. Also, we can see the pressure overload if we see the left ventricular hypertrophy in hypertension patients. If the patient is with a right ventricular hypertrophy, we can see it in a pulmonary stenosis, in some chronic thromboembolic lung diseases. Volume overload, we can see the volume, both of pressure and volume overload in hypertrophic conditions, and also in regurgitations of valves, mitral and aortic regurgitations, and we can see also in a hypervolemic patients. For example, if the patient have a chronic kidney disease and take dialysis or the frequent hypervolemic conditions, we can also see the volume overload of the left ventricle and right ventricles, and we can see sometimes these criteria on ECG of these clinical conditions in such patients.
Thank you. I have a question. Is there any pathology which causes increased left ventricular mass index, but there is no left ventricular hypertrophy on ECG?
On ECG. I didn't face with such patients, but there is some infiltrative myocardial disease, or some, for example, the patients after myocarditis, which faced with myocarditis previously, and then he can come with a high amount of LV mass index. And in which other conditions we can see it?
And also steroid disease like amyloidosis. Like amyloidosis, like Fabry,
amyloidosis, Fabry's diseases
can increase the left ventricular mass, but there is no left ventricular hypertrophy on ECG. There is low voltage. Another question from Özge. Which left ventricular hypertrophy criteria do you usually use in clinic practice?
Especially Özge, I use Sokolov and Cornell criteria, especially them, because they are very practical and simple.
Okay, thank you. Is there any question from the audience? Please feel free to ask. I think no more question. Now, the end of the second day, I want you to open your cameras to say goodbye, to close the session. Please open your cameras. Thank you. Serjan, do you want to say anything? Close the session.
Yeah, thanks a lot for both of you. And Chiesa, are you here? Okay, I think she might be busy. Okay, so you can close the session, and yeah, she come.
I think one more thing. The audience want to take the presentation. Is it possible?
Yes, we will send the link.
Okay. Okay.
Özge,
one question. Can you remind us the time of the next week division from here?
Yes, it is a good point. Now I will again share my screen. Yes, it will be our second week, and in the 11th July, and it will be the Central European time at 2 p.m. We will start with ECG in coronary artery disease. Özge will present to us, and then the second presentation is also very interesting. The Kader Eliz will present us ECG in electrolyte abnormalities and drug effects. So see you next week.
See you then. Have a nice Sunday.